In this episode of TIC Talk by TAC, Jacqueline and I caught up with our brother, Dr. Rick Busch. Dr. Busch uses the DRS protocol to help patients with back pain, sciatica, herniated disc, and even failed back surgery. This edition, we talk about his article in the January issue, helping patients avoid another failed back surgery. Listen on to hear what the CashMasterPractice.com developer has to say on this topic. So welcome. Here we are with Dr. Richard Busch III to talk about the article in the most recent issue with his article on decompression for failed back surgery. I'm your host, Dr. Joe Busch, and this is my sister, Jacqueline Toussard, who is the publisher of the American Chiropractor magazine. And we are joined by our brother and famous chiropractor, Dr. Richard Busch. So, Dr. Busch, thank you for coming on our program. This is TAC Tic Talk, and we're here to talk about everything that you've been doing, especially with regards to this failed back surgery and how we can help patients overcome the suffering and struggles that they encounter.
Well, thank you for having me. I really appreciate it, guys. It's always fun to talk to you all. And let's just get started and we'll get anything that we need to answered. And obviously we know each other pretty well, so this could be a really interesting conversation, or it may be really dull. I'm not sure.
No, I don't think it'll be dull. It's never dull with you, Rick. If that's okay if I call you Rick.
That's fine. That's all right, Jose.
So now, what kind of problems do you treat with decompression, Rick?
Let me just give you a little background, or at least for the viewers. We started using spinal decompression in 1996, 97. Okay. As far as that's concerned, we started with the DRS system at that time. And from there, we started to develop what's called the DRS protocol. DRS stands for decompression, reduction, and stabilization. And that's really what we're doing with the treatments. We're decompressing nerves or taking pressure off of them, reducing disc bulges, and stabilizing the whole thing so the problem doesn't return. The reason that we developed the DRS protocol is because I did want to make sure that we're a little bit different than a lot of people who are just using spinal decompression. With that being said, when we talk about spinal decompression, what we're working with is we're working with patients that have herniated and degenerative discs, sciatic pain, numbness and tingling in their arms or legs, failed back surgery pain, facet syndromes, things like that. Basically chronic problems that in most cases haven't responded to other types of conservative care. And when we say conservative care, we're talking about just regular chiropractic manipulation, physical therapy modalities, in some cases acupuncture. They may have had some of the less invasive things like epidural injections, other over-the-counter medications. The patients that we in my office see, really, they've seen all of that. They've had, seen one to 10 chiropractors. They've had, 1 to 50, or epidural injections. 50 is a lot, but I mean, probably 1 to 30. I saw somebody yesterday who had 30 over the course of the last 10 years. Along with that, they've had failed back surgeries. 1 to 14 of those. After the second one that failed, I always ask them, what the heck were you thinking about getting the next ones for? But those are the people that we really work with. Really, I work with more chronic pain than anything else. And they're the patients that most people really don't like to see because, frankly, they're really hard to deal with in a lot of cases.
Meaning their personality is really charming, too, because they're in a lot of pain.
Hey, people who are in pain are generally not as jovial as you and I. In many cases, they do. They're generally a lot less nice, to put it bluntly. But along with that, the thing about it is, when I talk with patients, a lot of times I explain to them that, as we help them get better, we're gonna actually help. And I tell their spouse this, that we're gonna help make them nice again.
Right.
And when we work on this, we have to realize that as we're helping these patients get better, we're not only helping them, but we're helping everybody around them. So we're helping their relationships with their spouse or their family or the people that they work with. And so as they start to feel better, obviously they're a lot more fun to be around. And so it's amazing to see the changes that we see in the patients' lives.
Right. Well, and I wanted to add in here too. I just jumped up because I wanted to reach over across my desk in my office here. I've got your book,
Mm-hmm.
Freedom from Chronic Neck and Back Pain Surgery Not Included.
Yeah, that's the first edition right there. And then this is the new edition that we just finished last year. It's got all the updated research and everything else up through 2020, 21. So that's basically the newer edition on your left.
Now, Dr. Busch, sometimes people would say, that the failed back surgery or spinal fusion is contraindicated,
Uh-huh.
or so you're actually taking that next step in treating with this DRS protocol on these types of patients? How does that differ than your typical, say, traction device or whatever people are, just throwing them up there and seeing how it goes?
No, actually, it's a great question, because a lot of people look at spinal decompression as just traction, plus. And
Mhm.
the biggest way that I can describe this is, if you're doing true spinal decompression, a lot of it has to do with not only what your intention is, but also the type of equipment that you're using. And so, the idea behind it, if you take an X-ray, or I guess what's the best way to ask this is, what's the biggest difference between an X-ray and a CT? The computer systems, right?
Sure. Yes,
So
absolutely.
the computer system, the interpretation of the X-ray by those computer systems. And in a lot of cases, what we're using, as far as the quality of equipment that we're using a computer system that allows us to measure different types of tension, movements, and everything else. And then along with that, applying a force over more of a logarithmic type of a wave, so that we can overcome the muscle spasm that accompanies traction in a lot of cases. It allows us to apply a lot more force. So most people are limited to, or with traction, they're limited to about 50 pounds of force. And then we start to see muscle guarding in the area. And so as a result of that, we're talking about lumbar spine, obviously. And so by applying that force in a different manner and using a computer system that's actually allowing us to overcome those muscle spasms, that we can actually have a lot greater response. So instead of just pulling the facet joints apart on the backside of the spine, we're actually pulling the entire disc level apart by allowing those joints or those muscles to relax. As we do that, that helps create the pressure gradient between the inside and the outside of the disc, which allows us to bring in oxygen, water, nutrients, everything the disc needs to heal. And as we do that, we can actually begin to not only heal the disc from the inside out, but at the same time, we're creating a pumping action so we can get that waste material, all the edema and everything else that's in the area. We can push that stuff out, and that's generally what's causing the damage to some of the soft tissue in the area, and creates more degenerative change. So what we're doing is we're giving the body what it needs. We've always known, as chiropractors, we always known the body can heal if it's given the proper situation. So really, what I'm doing is I'm just working to give it that situation. And then when we talk about things like the DRS protocol, this is not just an event you put somebody on a table for. Okay, what we're doing is we're adding different types of modalities so that we can actually get a better result. We can help with inflammation, we can help with the muscle spasm, we can help with blood supply oxygenation, all of those things, and help promote the healing process. And as we do that, obviously we get better results that way. As far as surgery is concerned, if you have a discectomy or a spinal fusion or anything like that, their success rate really, and these aren't my numbers. This is the Orthopedic Society's numbers. They run 20 to 30% over 5 years. That's a 20 to 30% success rate for the pain. Now, if you talk to most people before they get surgeries, they say, I talked to the orthopedic surgeon and he said that we're going to be 80% successful. But when they say 80% successful during fusion, they mean they're 80% successful, that they're going to be able to make sure that bone is fused together, and that they're going to be able to stop movement at that joint level.
Oh, wow.
The problem is, from a long-term standpoint, that's not a great deal for the patient. So the patient's going to end up with, we know after surgery that the patient's going to end up with either chronic pain, changes in range of motion. In many cases, they're going to take some opiates or things like that to help with the pain, anti-inflammatory medications. All of those have side effects. We know that steroid injections, the steroids work like a sponge, so they pull all the good fluid out of the soft tissue, out of the cartilage and everything else, and it weakens the connective tissue, or the tendons and the ligaments in the area. So it makes everything else weaker, and it causes those problems to continue. So the idea behind what we're doing is we're just helping the body heal the way that it knows how to do.
So as far as you're concerned, are those patients completely healed when you're finished with them, or how does that?
Well, that's a great question, because a lot of patients ask that question all the time. And you start to look at this, if you have a chronic degenerative change that's taken place over the course of 20 or 30 years, what we're going to do in the course of 6 to 8 weeks isn't going to make them like they were when they were 18 again. Okay, unfortunately, I haven't been given that power, either of you or as anybody else that I know. But when it comes down to it, what we're doing is we're working to help the body heal what's left. Okay, and then the idea is, if we can restore normal movement or close to normal movement and get them back to a normal type of an activity level, either without the pain or with a great reduction in the pain, that's obviously a pretty great deal. And then when we're finished, I do recommend supportive care for every single patient. And now we see a lot of patients from a maintenance standpoint for chiropractic, right? I mean, when I talk with patients, I explain it's a lot easier to stay in shape than it is to get in shape.
Right.
Right.
And
That's a
so,
great analogy.
when you start to think about it, I mean, I need to get myself back in shape again, so I got to get back in the gym. I got a lot of hard work to do. It's the same kind of thing when we're dealing with disc problems.
So what insurance like for this, Rick? I mean, Dr. Busch, does this get covered with it? Or I mean, how does a person who's suffering from these types of conditions, approach you and
As far as insurance in the United States, it's like it has been ever since they introduced the Affordable Care Act. Okay, as far as that's concerned, obviously they're reducing their coverage for almost everything. In many cases, though, people have medical savings accounts, and the whole purpose behind that is because they all have really high deductibles. So as far as surgery is concerned, they're going to have a huge out-of-pocket expense for surgery in most cases. And the way that we work with our patients in my office, before we begin any treatment with them, we will sit down and go over really what their problem is and what we need to do to help. So then we talk about how often we'll see them over what period of time and expected outcome, as well as any fees for the entire treatment. In some cases, there is some insurance coverage. In other cases, there isn't any. And I think it's very important to make sure that the patients understand that before they begin anything. But either way, what we're doing is really still a lot better deal for them than what they would be doing from a surgical standpoint. And the outcomes are a lot better as well.
Right.
Wow.
Well, that's what intrigues, I think, someone who's out there contemplating between the two options, surgery or, try to rehab it. Definitely the outcomes would make you motivated to want to, do your best to avoid any surgical intervention based on the numbers you're citing, which are the surgeon's own evaluation of their techniques, right? So,
And actually, that's something that I've gotten from surgeons around here. I've asked them what their statistics are as far as long-term recovery. And most often they're actually telling patients that now, especially if they've had if they're going to have a fusion.
mm-hmm.
I had somebody come in the other day who said that, he went to see the surgeon. He got a fusion 8 years ago, and the surgeon told him that in 3 years he'd be back with a very similar problem and have to have more surgery. Well, the guy toughed it out for another 5 years beyond that. He's been in a lot of pain ever since.
Mm-hmm.
At the same time, he has had some regular chiropractic care, and it helped with the pain for very short periods of time. I do think it's important, from the standpoint of what we do here. I'm a chiropractor, and I treat patients with regular chiropractic every single day. I adjust patients every single day. I adjust these patients, not every single treatment, but we do adjust them because it's a huge part of their care. It's one of the reasons that when the PTs, when there are some physical therapists out there that are using forms of spinal decompression, there are some medical doctors that are actually, I've trained medical doctors to do what we do in my office, and they're using this type of treatment. The one thing that they're missing is they're missing the adjustment or the manipulation as well. And so that's not something we do in every single case, but at the same time, it does help benefit those patients and help get better results.
See, Rick Jackman, he's talking about the tick right now. That's what we're talking about, Rick. This is tick talk. This is not decompression talk, Rick. Dr. Busch.
Dr. Joe, I think for the record, I'm just going to say that since we're all siblings, our listeners can understand if you call
Hey,
each other.
baby, you can call me Rick, okay?
We're just going to keep it on the nicknames that are appropriate for the podcast program, though.
Mm-hmm.
Okay.
That's fair.
This could go south really fast. So let's just keep.
Could be bad.
So, Rick, then what kind of techniques are you using on these patients? I mean, they're clearly not all able to receive every type of treatment technique, and I'm sure you use a different variety of techniques.
Oh no, that's a really great question because there are a lot of people who when they see a patient, you've got the patients that like to do just regular diversified side posture stuff.
Mm-hmm.
The problem is after they get done with that type of a treatment from a spinal decompression standpoint, the muscle spasm or the muscles are weak, and so there is some instability in the spine. And as a result of that, if you side posture them, they're going to be more likely to help re-injure one of the discs. Mm-hmm. So what I recommend is I recommend using pelvic drops for that. And in many cases, we look for. I do a lot of the Thompson listings for those as well, so that we can kind of determine what's best for the patients that we're treating with cervical spine disc problems. I like to make sure that we treat most of them P to A as well, mm-hmm. So that we're avoiding too much rotation. because again, that can cause more shear force on the disc and can cause other problems later on. And it heals slower that way too, I think.
When there was the talk about the back pain and the surgery, okay? My question is this. Are there many that will go under treatment? Because I'm guessing one of the problems you have is, and obstacles, as I know friends who I try to get into the chiropractic clinic or decompression, and they're always, favoring the medical angle. Are there people who will go through the decompression program and still end up having to do a back surgery? Are there many of those?
Very few. It's probably less than 1%.
Okay.
As far as the patients that we work with, if you think about it from the standpoint of the research that's been done with some of the different types of tables out there, whether it's and I'm talking about the more advanced tables like the North American medical tables like the Acuspina or the TRX 9000s, with those tables, they're using a little bit different type of a program. I think it was 1996, they did a study with the DRS system originally, and they came up with about an 86% success rate in working with patients to help them resolve their pain, and get them back to normal lifestyle. I've seen other results from North American since then, and also from some other studies as well, which show closer to a 90% success rate in helping patients with better than a 70% resolution of pain. What we've done in my office is actually even a little bit higher than that. And so the idea is, if you think about it from the standpoint of overall, if you're dealing with back problems, one of the most common, actually the most common reason for patients to take time off work, and this is one of the statistics from the Department of Labor, is I think it's about 80% of the population at some point in time will take time off because of a back-related injury. Okay, and that's during the course of their lifetime. That's not during the course of a year. So when we start to realize that, then we realize everybody's got some type of back pain at some point in time. Most of those patients do resolve with regular chiropractic care. Then we have the patients that are more advanced that they're not resolving with that, and their only options are either more epidural injections or surgery. And what we've seen is there's kind of a flow chart for the way that people are managed in healthcare nowadays if they have back problems. And so what happens is we call it back and neck pain pipeline in my office. And the idea behind it is, the first thing is they go to their medical doctor. The medical doctor goes, you know what, you've got a disc or you've got a back problem. We're going to start you on some anti-inflammatories and some muscle relaxers. And then the patient comes back and says, hey, doc, you know what? The anti-inflammatories and muscle relaxers didn't work. So what do you think I should do now? And they say, well, we can do one of two things. Probably we should send you to a physical therapist. And they do some exercises at the physical therapist for a little while. And then they go back to their medical doctor, and the medical doctor says, you know what, geez, this isn't really working right. Let's send you to one of the orthopedic or the neurosurgeons. We'll just check it out. We'll send you to a specialist. And they send them to the specialist, okay? And the specialist says, he says, you know what, they didn't do quite enough physical therapy for you, because we have to do at least 6 to 8 weeks of physical therapy before I'm allowed to order an MRI under your insurance. So we're going to send you back out for more physical therapy. And once they finish that up, they come back and they say, you know what, I think we're going to shoot some films, or we're going to have an MRI done. They do the MRI and they come back and they say, you know what, you have a disc problem. And then after they say you have a disc problem, they say, we've got 3 options. We can do more physical therapy and see if that works, but it hasn't worked so far. We can do an epidural injection and some more medications, or we can set you up for a surgical consult. Well, I'll tell you what, and so most people at that point say, well, let me just do the shots. Or some people now are going, you know what, I'm not sure what's in those shots. I'm a little bit nervous about it. Right. They'll go in and get an epidural. And generally speaking, they're looking at a battery of 3 epidural injections. The problem with the epidurals is the steroids that are in them, they dehydrate, as we talked about before, they dehydrate the cartilage in the cell. They pull the fluids out of the cell, out of the cartilage, and they make the soft tissue in the area work, or the connective tissue in the area weaker. And so they can create their own problems that way. So they accelerate degeneration, though. And then the next thing that happens, once that doesn't work, they go back to the surgeon. The surgeon says, you know what, we're going to have to do surgery on you because nothing else is working. Okay. And at that point, a lot of patients will go, you know what, wait, I've heard surgeries don't turn out well. And so in those situations, they usually come to see me either right before they had the injection or right after they had the injection. Those are the people that we're actually working with. But then the idea with that is that those people, if they don't get treatment that way, this is the back and neck pain pipeline. The next option is surgery. Don't come and see me. Okay, so then they go to surgery. And the whole thing starts all over again because it becomes a vicious cycle. It's not something that ends. It's almost like the back and neck pain merry-go-round, I guess is probably a better way to say it.
Wow.
Because it
I
just keeps
wonder how
happening.
much time and money that really, eats up in people's lives.
Without a doubt. Now, Rick, you've educated people in the past on this topic. You mentioned you've taught medical doctors and physical therapists, chiropractors as well. Are you still doing that? Are you still teaching chiropractors how to do the DRS protocol? Or
Oh, yes. And you remember we did in the past, we did something called the Busch All Cash Academy. And that was where we'd have patient or doctors come in with their staffs. They'd spend 3 days with me in my office and my staff so they could actually see what we're doing on real time. I'm one of those people, seeing is believing. And if you can actually experience it, I think it's even better than that. And so when it comes to people telling me what they're doing in their office, I don't really believe it unless I really see it. And with COVID and everything else that's gone on during the course of the last couple of years, no matter how you feel about COVID, and I'm not going to talk about that today because I start swearing too much. That's a whole other story. But we put something together called Cash Master Practice, or cashmasterpractice.com. And the idea behind this, all the training that we were doing in person, we pretty much put up online now, so that we can have doctors be able to interact not only with the videos that we have for training their staff and training the doctors to be able to first of all do a good history and a good exam for these patients. It's very important to make sure that they're being handled correctly or managed correctly, and then also doing a good report of findings for them, because in many cases we are working on more of a cash basis with these patients. So we want to make sure that we're getting the proper information from them, so we know exactly what we need to do. And then along with that we're able to give them the proper type of a report of findings, so that when we're all finished, it's not a hard sales pitch. It's basically, this is the information that you need to know.
Right.
You can make a decision now. Does it sound like something that sounds like a good idea? Does it make sense to you? If it makes sense, then most of our patients actually decide they want to take care. If they don't, then you know what? They will return it later in many cases. But with that, it's vital when we're working with patients on a cash basis, like we do in my office, where and I'm talking about a prepaid case fee type of a practice, as opposed to just charging a visit by visit. But it's vital to make sure that your staff understands what you're doing and knows how to manage those patients, knows how to schedule them properly, and actually discuss the hard things like scheduling and insurance, and how everything actually works with that. And that's not really the hard thing, but it's actually really one of the easier things, one of the easier topics to manage if you're working with the patient correctly, or if your staff is. So we've got videos that can help not only identify the different types of patients, but also along with that, how the patient should be handled on the phone or talked to on the phone, what the things that the staff needs to express to the patient so they understand, so that they actually get in and make their appointment, first of all. And second of all, then when we're all finished, they take care and get well. I look at things a little bit differently than a lot of people, from the standpoint of my one goal is to help people get well. I know everybody wants to help people get well, but when you work with patients in the manner that I do, where we're working on a prepaid case fee program, basically the only thing that matters is what the result is at the end.
Right.
Because if we're not getting a great result, if we're not getting patients well, if we're not helping with their pain, if we're not helping restore their quality of life, then you're not going to be in practice for very long when you work with patients the way that we do.
absolutely, yeah, that's the proof right there. And you're right. It's like the surgeon will charge the $50,000 or $100,000 for the surgery, and after that, it's like, what? You've got a new condition. You got a failed back surgery now. So
that's exactly right.
The insurance company paid for it, though, so don't worry about it. But the chiropractor, when we're talking about cash, and while it still has value, then we have to be, really aware of that. And you've been doing this for how long? Have you been doing this, Rick?
26 years.
Jesus Christ, Rick, 26 years, seriously.
No, actually, I thought the same thing when I got up this morning.
So
it really is. It's amazing to think that we've been doing this for that long.
Cashmasterpractice.com then. So is this a subscription service, or is this a module-based learning program? Is it CE, or how's that work, Rick?
Well, we're working on CE with it right now, and along with that, this is a training program. This is really it's kind of a business in a box, if you will. Okay, basically, if somebody wanted to take the program, and you said, you can get it at cashmasterpractice.com, or you can call my office 260, or actually 888-471-4090, and just talk to somebody here. but the idea behind it is it's a whole program where you can actually learn how to train your staff to work with these types of patients, and how to put the entire program together, the entire process together. I think last I checked, there's about 20 to 25 hours worth of material in there if you really want to get into it and learn about what we're doing. There's even a video of one of the lectures that I gave to an actual class that came to my office. Early years old, I do look a little bit younger there. But at the same time, most of that information, the information has not changed. So we put this all together to make it easier. And then along with that, we're still allowing doctors to come to our office and train here if they're interested in that as well. Just to let you know, in reality, if you were to spend probably 2 to 3 hours just learning the consultation, the history, and the report of findings, it will do an amazing amount of benefit for your practice.
Now, Rick, you're in Fort Wayne, Indiana there, so everyone knows. I don't think we mentioned that. So same building. You're not hopping towns every couple of years, I guess, right? You just
I've been in the same place since we started from scratch 26 years ago.
For 26
How many tables do you have up there, Rick? How many tables are you using on a daily basis?
I think we have about 10 right now. 10 or 11.
10 or 11.
Yes.
Holy smokes.
Are you talking about regular chiropractic tables, or are you talking about decompression tables?
No, this is spinal decompression tables. So we've got 10 of those.
Wow.
And and you know, and I still see patients with regular chiropractic. I 3 adjusting rooms, 4 tables. And along with that, though, something that we're going to talk about in the future is, I also use other therapies. Whether it's things like the shock wave, those types of things to help break up scar tissue, adhesions, arthritic changes. I do use those on patients. We use lasers, different types of low-level light therapy as well. There are a lot of different types of treatment that we use. And again, as I mentioned, my only goal or my only focus is the outcome at the end, and that's making sure that we get a successful result. So I have a lot of different types of equipment in here. I've got more equipment in this office than probably most chiropractic offices in the country or the world. And the reason is because, there are times where we need some of those extra things, some of those extra modalities just to be able to help get a better result.
Right. Well, that's amazing because it's very inspiring too. I'm just thinking about all of our listeners who are chiropractors out there who may or may not have incorporated this type of technology, who may have family members with back problems. I mean, this is a reality. Chiropractors themselves end up finding different tools because of their own personal health issues. So sadly, but this is very exciting. And of course, I'm sure another good way to add more benefit to the patient and help with their practice bottom line too.
Outstanding information, Dr. Busch. Thank you for coming on TikTok by the American Chiropractor magazine. Look for this article, Helping Patients Avoid Another Back Surgery, in the January 2023 issue of the American Chiropractor magazine. Jacqueline, anything
one last
that you have pending on your brain?
I wanted to add in because this upcoming year, this 2023, it's currently December 2022 and we're talking. But this will be launched in 2023, and it is our 45th year anniversary of the American Chiropractor magazine, which I didn't want to jump on your stuff, Rick, but I was starting with the magazine right as you were starting off in chiropractic. So I can also tout 26 years because you had just graduated from chiropractic school, been heading up the magazine, and I believe your inroads into decompression somehow were affiliated with the involvement in the American Chiropractor. If I'm not mistaken, I think you've gotten exposed to a lot of different technologies and things, and early on, right?
What's interesting for me is I've always, I like technology. I really do. I'm what would be considered an early adapter. I like to find those things and figure out how we can actually make all this stuff work in different manners. And that's one of the reasons I've got so much technology around here. And a lot of that really came, and the exposure really came from being involved with the magazine to begin with. So I was able to talk to some of the people like Norman Shealy, who started North American Medical, or actually DRS back then. But so interviewing all those people back when we started, and then along with that, having access to a lot of the different information that you all offer. And obviously I read the magazine as well. I mean, I check up on you guys all the time. And so it gives you another perspective. And, one thing that I think as a profession that we have a tendency to do is, obviously we work with our hands, but you can't discount some of the other technology that's out there as well, because all of those things put together, that's what the whole DRS protocol is. It's a whole bunch of different technologies that we put together to get better outcomes.
Mm-hmm.
And that's the same type of thing that we do with regular chiropractic. And
Right.
it's just something that, because again, what we care about are outcomes. And I know what most of the doctors listening are interested in as well. It's great outcomes.
Mm-hmm.
Love
Right.
it. I love it. And that's exactly what we should be doing for our patients, right? I mean, we've got a different set of tools. We can work with the human body's ability to heal itself, as well as what nature and the environment has, without creating effects which cause
Mhm.
negative outcomes. So,
Mhm.
Mhm.
Well, and I was going to say really quick before closing up, because I know we're kind of at about a 30-minute window already, but I wanted to mention too, because I know that there's the back surgery, there's the decompression option. And then of course, once they're out of that, I know all these other modalities, I think, straighter chiropractors or the more traditional are always looking to probably go to the root cause then to prevent the recurrence. And that's, what the ongoing, I guess, chiropractic care. So it's kind of like, we're trying to prevent it, but once you're in a crisis care situation.
It's not only that. I mean, also you have to think about the nutrition. I mean, if you start really looking at this, there's
Mhm.
not one cause to all this. There are a bunch of causes. And so
Mhm.
the idea behind it is, and it looks like Dr. Joe here has to keep going too, but
Mhm.
the idea behind it is you got to look at the nutrition, you got to look at the function, you got to look at everything else. And
Mhm.
those are all things we have to do. But
Mhm.
other than that, I really appreciate you guys taking the time with me today.
Well, this is
no, it's
why
fun.
actually, as a look back to our 45 years, and of course you 26 years with us too, which is why we'll be seeing more of you in the American Chiropractor, and hopefully another visit or two on the podcast throughout the year as we get more of that going as well. So
Sounds great.
good to see you,
Appreciate,
big brother.
appreciate it, guys.
Dr. Busch.
All right.
Thank you.
Bye-bye.
Thanks.
All right.